Good afternoon. Welcome to the 7th international webinar organized by Vets and Clinic Vet Band. My name is Alba Martos. I'm the International Vet Manager in Affinity Care. Today we met Elsa Beltran and we will discuss a very important issue that raises many questions in the veterinary community, which is canine epilepsy. We will talk about different issues related with this disease, science, treatment, etc. But well, before starting, let me introduce Elsa. Elsa has a diploma in veterinary neurology, and currently she's working in the Royal Veterinary College in London, where she teaches both neurology and also neurosurgery. So good afternoon, Elsa. Thanks for being here with us today.
Thank you so much. Thank you for the invitation.
So well, to all our attendees, take advantage of this opportunity to enjoy this webinar and ask all the questions you have. At the end of the sessions, we will answer all the questions, but in case we don't have enough time, on the description of this webinar, you will see an email direction. So any question that we cannot answer at the end, you can send it to this direction, to this email, and Elsa will answer all the questions. On the other hand, also remember that you can download the presentation clicking on the link you can see below too. And well, that's all I think from my side. I will not delay any longer and we will start the session. As I said, we are going to talk about canine epilepsy. So Elsa, the first question I have for you is that you can describe us what epileptic seizure is.
Okay, thank you so much. So yes, as Alba said, this lecture is we're gonna be talking about canine epilepsy, from those clinical signs to treatment. But we need to go to the basic question that you ask yourself. What is an epileptic seizure? If you have to describe an epileptic seizure, how will you do that? So when we describe an epileptic seizure, is that a manifestation of excessive and simultaneous that electrical activity in the brain, and is self-limiting. So when we have a clinical sign that is consistent with seizures, what we can say that we know is a dysfunction of the forebrain. So it's just a clinical manifestation of what is known as the thalamocortex. That area is not functioning properly. But an epileptic seizure is not a disease itself. So it doesn't tell you the type of disease. It tells you that it's a clinical sign of forebrain dysfunction. So when we have to think about what are the clinical signs compatible with an epileptic seizure, so what are those clinical signs that you can say for sure, I know I'm in front of an epileptic seizure? So as we said, taking into account an epileptic event, an epileptic seizure is that manifestation of electrical and simultaneous electrical activity in that brain. We can see that as a generalized tonic-clonic seizure, and that is a typical that we probably see as manifestation of this abnormal electrical activity with all the body being involved. So and then when we have that area, but only one area of the brain that shows us electrical activity, that will be manifested as a focal electrical activity. So remember that, as we said, a clinical signs of abnormal electrical activity is what we define as an epileptic seizure, and that comes from a forebrain dysfunction. Forebrain also controls contralateral movement. So if we have an abnormal electrical activity that, for instance, starts on my left forebrain, will be my right side of the body, the one that is going to be manifesting that abnormal electrical activity. If, on the other hand, the abnormal electrical activity affects all the brain, then that abnormal electrical activity will manifest it at all the body being involved. So the typical is the generalized one. When they lie down, they have this increased tone, they have these paddling movements, they have loss of consciousness, but it's not a loss of consciousness as the one that we say, oh, is totally unconscious, because if you ask the owner, they will tell you, yes, the eyes are open, but they are not aware of the surrounding, because that forebrain dysfunction is what is manifested as not being aware of what's going on. So what we classify as not being conscious, but it will not be the clinical unconsciousness when they lie down and then close those eyes. So as we say, when we have a generalized seizure will be all the brain. That abnormal electrical activity will be affecting all the brain. However, if we have a focal, will be just one part of that forebrain that has that abnormal electrical activity. But remember that even if we have a focal electrical activity, we should act medically to try to stop it, because otherwise that abnormal electrical activity can generalize and become a tonic-clonic seizure. So when we classify that focal electrical activity, it can be manifested as autonomic signs, so typical hypersalivation, and then usually goes with these motor disturbances, so focal twitching, mainly manifested with the face. Sometimes can be manifested as abnormal behavior, because imagine one area that could be having that abnormal electrical activity is the occipital lobe. The occipital lobe is mainly in charge of vision. So if we have an abnormal electrical activity at that level, we could be seeing like imaginary objects. So this is why sometimes it's manifested in dogs as the fly catching. We know that in some occasions fly catching could be associated with some alteration on the behavior, but in some occasions could potentially represent abnormal electrical activity in that area of the brain. And as we said, you can see this little Frenchie that had some structural lesion on the left part of the forebrain, and mainly was manifested as a right-sided focal twitching. But if that was not stopped at that time, that could be converted into a generalized tonic-clonic seizure. So as we said, it's important that if we recognize a focal seizure, we try to stop it at that time, because then we may prevent that episode to generalize. When we talk about generalized seizures, it could be the typical convulsive, as we said, the typical tonic-clonic, when the dog is on lateral recumbency and then he loses the consciousness, he's not aware of the surrounding. It's a self-limiting, as we said, so usually lasts a few seconds. And then after that, we'll talk about that, but it's that this postictal phase where that forebrain needs time to recover. Sometimes it can be manifested just as clonic, so only this increased tone. Sometimes can be manifested just as the clonic, so just the movement, so tonic increased tone, clonic just the movement. And sometimes it can be manifested as these myoclonic seizures, which is these jerks movements, mainly because of the contraction of the muscles of the face and the neck. There are also the non-convulsive generalized. Imagine if they are not convulsive, they are like atonic. Atonic seizures are extremely rare. So prior to make the diagnosis of a clinical diagnosis that those clinical signs could be consistent with an atonic event, make sure that we rule out any other potential cause of placid, so cardiovascular, something systemic. So prior to as we said, make it as an atonic seizure, because they are extremely rare and common things are common. So the first question that we need to ask ourselves is it an epileptic seizure? Yes or no? And sometimes it's not so easy to answer that question. Because as we said, when we want to answer that question, is an epileptic seizure yes or no, what is important? Important is that we focus asking the owner about the phases that involve that epileptic event. I know this is not a dog, but it's a nice video to explain the different phases, which are similar and can be extrapolated from this little kitten. So the phase that we clinically see as that epileptic event, and that's simultaneous electrical activity in that brain, could be presided by the prodrome phase or the aura phase. The prodrome, many owners will not be able to, or many dogs may not manifest that. So, but some owners may say, my dog today or tomorrow is going to have a seizure. If that's the case, that's very important, because there is some medication that potentially we can give at that level, at that phase of the potential prodrome. The aura is just a few seconds, so just before the ictus. The ictus is that abnormal electrical activity in the brain when they have this either manifested as tonic-clonic or myoclonic. And then the most important to recognize an epileptic event is the posictal. Imagine if you have that abnormal electrical activity in the brain, that brain needs time to recover. It's not going to stop the seizure and suddenly it goes back to normal. It may take a few seconds, it may take a few minutes, but there is always a posictal phase in this typical tonic-clonic or even on the focal seizure. And then we have the interictal. To know the interictal is important, but again, this is the video where the ictus is and the interictal between those two ictus, or between ictus. So interictal phase, that dog should be evaluated for any potential neurological deficits, because it means that the ictus has already recovered, that abnormal electrical activity in the brain has already recovered, and the interictal phase is the important phase that will allow us to evaluate the dog to see if there are any other or any potential neurological deficits. During the posictal phase, do not rely on the neurological deficits, because any dog will manifest to have neurological deficits as a forebrain dysfunction. But that brain needs to recover. And when that brain has recovered from the ictus, then we will have that interictal phase. So what are those potential posictal clinical signs? So anything associated with a forebrain dysfunction. So they may have altered behavior, they may have some increased appetite, they may have this compulsive circling, they may have some blindness that the owner may describe as being blind, but because obviously you have some abnormal electrical activity in that brain, then what can happen is that dog or that cat is not able to really perceive what is seen. So they may manifest as being blind, and they usually take time to recover. Sometimes it's a matter of hours, sometimes it's a matter of a few days. But as I said, don't rely on your neurological exam on the posictal phase, because they will have decreased menace response, they may have some gait abnormalities, and that doesn't mean that they are permanent deficits or they are deficits that represent a potential structural lesion in that brain. It's just the posictal phase. So if you do the neuroexam and it's normal, perfect. But if you do the neuroexam and it's abnormal, remember that could be due to the posictal phase. So wait until that forebrain recovers from that abnormal electrical activity in the brain. Potentially, the one that are an exception on these myoclonic seizures are, sorry, an exception on the posictal are the myoclonic seizures. So the myoclonic episodes are these brief jerk muscle contractions, and you can see the little miniature white-haired Dachshund. When they have these jerks, muscles, they occur with different underlying cause, but it's just this muscle contraction of the head and the face. Sometimes it's due to light stimulus. Sometimes it's just for the sunlight when it's with some shadows, and they can really have these episodes of the myoclonic seizures. Those abnormal electrical activity in the brain are the exceptions, that they don't have any posictal phase. So don't rely on the posictal. This is, as we said, everything that I just told you that before, that you really need to rely on the posictal. When they have a myoclonic seizure, they don't have a posictal phase, but the episode are quite characteristic of this contraction of the head and the face. And as we said, hopefully all of that will allow us to answer the question, is this epileptic seizure, yes or no? And why is that important to know? Because then obviously we can make our list of differentials based on a forebrain dysfunction because of epileptic event, or a potential other underlying cause.
So thanks, Elsa. During this first slide, you have repeated several times that it's important to differentiate epileptic seizures from other processes or other pathologies. So I don't know if you can explain us which other pathologies can be with these clinical signs.
Yeah, that's a very good question, Alba. So as we said, what are the other pathologies? Because as we said, yes, we can identify a seizure, or we think it's a seizure, what are the other potential differentials that we should consider that are not epileptic seizures? And this is a brief group of disorders that they are called movement disorders, or also the paroxysmal dyskinesia, and is manifested as that inability to perform voluntary movements. And the pathophysiology is not well understood in the majority of these movement disorders, but clinically what they manifest is by, as the name say, by this inability to perform voluntary movement. So as you can see, based on this description of this definition, the mental status should be normal. And this will be a key point that are going to allow us to differentiate an epileptic seizure from paroxysmal dyskinesia, and then the posictal phase. I'm just going to put you a few examples, but as a summary, as we said, is usually inherited, although the pathophysiology is not known in the majority of the cases, and is mainly characterized by this inability to initiate movement. Sometimes it can last a few seconds, a few minutes, even hours, but clinically, the onset is very acute, and when it finishes, it's very abrupt. So doesn't have that posictal phase. And this is something that nowadays the owner can video the episode, and although the dog may look stressed, may look like, oh, that facial expression or what's going on, but they are not unconscious, in the meaning they continue to perceive the surroundings, so should really respond or follow objects or respond to the owner, not commands obviously, but reactions. And the owner can say, yes, I think is there, but obviously could, as we said, it could be very, very stressed. So when we have to characterize these movements, the majority, it will be that they don't have a posictal phase, and during the episode, the mental status remains conscious. And mainly, as we said, are characteristic by this cramp, this inability to start the movement. There are some breeds where are more or is more characterized in specific breeds, and even some of them we know the underlying cause. But what I want you to take from this, that any dog, any age, can manifest this paroxysmal dyskinesia. And I just want you to have some of the examples. Then it's important to know that in the majority, you may there is not a genetic test, so therefore we have to rely on the semiology. And it's important also to know that the diagnostic tests that we are going to do in these dogs, when we talk about advanced imaging of the brain, CSF analysis, all of them are going to return as normal in the majority of them. So it's important to consider how much we have to rely on the clinical signs versus putting the dog through all these tests that also requires general anesthesia, and they have a cost for it. So I'm just going to put you some of the videos where, again, seeing is believing, and about how to recognize these abnormal movement disorders. So let's start with this clinical case. It's a 3-year-old female spayed Cavalier King Charles Spaniel, and you can see he's lying in the kitchen floor. Is really have this tonic contraction, but look at the mental status. He's kind of looking around and say, what's going on? I cannot really initiate that movement. And this is why it's characteristic to differentiate from a true epileptic event where the mental status is impaired, but the tonic and the clonic movement could be very similar. But look how he's wowing the tail, and then try to stand up and kind of interact or change the contralateral limb. So you can see how both of them can be affected. They have this tonic contraction, this kind of cramps, and then try to initiate the movement, but it can not really do it. And look at the facial expression. It's like, what's going on? No, I cannot really walk. So the mental status is there, and then as soon as the episode stops, that the dog is back to normal. Doesn't have any of those posictal phase. The gait is normal, the mental status remains normal, and it doesn't have any neurological deficit. So in Cavaliers, what do we know of these abnormal episodes of this paroxysmal dyskinesia, these movement disorders, is also known as the episodic hypertonicity in the Cavaliers. You have another of these dogs affected by this paroxysmal dyskinesia. We know it's autosomic recessive. The mutation in this particular breed has been discovered, so there is a genetic test, so we can perform the genetic test when we have the suspicion based on the clinical manifestation. Unfortunately, there is not a curative treatment, but if we can modify that life activity, avoid the stress, some of them can be quite controlled, and otherwise we can do some trial on clonazepam, but they get quite resistant to it. So usually try to make this holistic treatment and try to avoid this excitement and see how we can control those episodes. But there is not a curative thing that is very important in these cases. And as we said, there is a genetic test that is available. Therefore, is the way when we suspect these cases to get to the diagnosis. Another paroxysmal dyskinesia that is well described is the one that happened in the border terrier. So you can see also how this dog is trying to initiate the movement. It really have this increased tone. Now it falls on his back. It really tries to stand up. It has this cramping movement. And again, it has been reported usually when they are less than 3 years of age. Is usually associated with the stress. The frequency can be variable, but can last. The average is around half an hour, but usually it's a few minutes. Some owners even describe hours. Has a variable of frequency, and at the beginning when we start seeing these clinical cases, it was reported that it was associated to barbarisms. They were investigated as potential epileptic events. So when a neuro exam was performed, MRI was also performed, CSA was performed, all of that came with no significant findings. Therefore, we didn't have an answer for that. And what it was seeing is that if the diet was changed, some of these episodes even disappear. And mainly when we use a hypoallergenic diet, mainly based on gluten-free. So what we got on these cases is that they had they improved with the gluten-free diet, and they had a sensitivity to the gluten. There is a gluten ataxia reported in human, which can look pretty similar. So when we see a border terrier with this symptomatology, it's important that we do a trial, and it's important that they stay just with gluten-free diet. And the majority, unless they have any other diet in his life, it should improve. So again, it's an easy diagnosis and it's an easy treatment if it falls in the characteristics of being a border terrier, has this paroxysmal dyskinesia, and what is the blood test for the autoantibodies for the gluten can be evaluated, but not many laboratories do so. So in those cases, just starting a trial, we should see an improvement within a few weeks of those episodes. And again, another of the movement disorders that we see quite frequent is in the Labrador retriever. Again, you can see this Labrador, the inability to initiate the movement. They are on lying on the floor, or they could even trying to start to initiate that movement and being very alteration on the gait, because in the end goes in the category of having these movement disorders. But look at the mental status. The mental status is not affected, and therefore that falls in the category of very not being a seizure, because it lasts too long, all the body is involved, and being a Labrador retriever is very likely it goes in the category of being a paroxysmal dyskinesia. Unfortunately, we don't have a final diagnosis in this breed, not in the Jack Russell either, but the majority of them have been seen that get better with time. So important to differentiate both.
Thanks, Elsa. So until now, it has been quite clear to us what epileptic seizure is and how we can recognize But going to the topic, the main topic of this presentation, when can we talk about epilepsy per se?
Again, that's also a good question. If we recognize, no, we have answered the question already, is this a seizure? Yes or no? Therefore, when can we talk about epilepsy? And epilepsy, if you have to define epilepsy, epilepsy is a predisposition of that brain to have seizures. And if we have to make a specific definition, we can even say that there are 2 or more unprovoked seizures at least 24 hours apart. Why is that important? Because we should differentiate from reactive seizures. So if we have reactive seizures, is when you have an extracranial cause that is upsetting that brain is and being the cause of the seizures. But as soon as you remove that extracranial cause, as soon as you remove that toxicity to that brain, the seizures stop. So you don't have a predisposition of that brain to have seizures. So if we talk about epilepsy and we use the word epilepsy, means that you have a predisposition of the brain. So important, we don't have to say reactive epilepsy because you don't have a predisposition with reactive seizures. So important that we call it reactive epileptic seizures. And epilepsy, we always have in mind that epilepsy is a predisposition of the brain to have seizures. Epilepsy can have different underlying cause. And remember, it's just a clinical sign of a predisposition of that forebrain to have seizures. It's not a specific disease. And we will see now the types of epilepsy that we have, but remember that reactive seizures is when we have something that secondary is affecting our forebrain function, and that could be toxicity, that could be metabolic, but as soon as that insult into that brain disappears, there is not any predisposition, and therefore we should not have seizures.
So now that we have discussed epilepsy a bit more and we know that we can distinguish different types of epilepsy, can you tell us more about them and their characteristics?
Yeah, thank you. So epilepsy, sometimes when you ask, oh, what is epilepsy, everybody assumes that epilepsy is idiopathic epilepsy. No, epilepsy, there are different types of epilepsy, and we have a structural, idiopathic, and the one that we know is genetic. So when we talk about structural epilepsy, what does it mean, structural epilepsy? Structural epilepsy means that there is a structure within that forebrain that is causing the seizure. So he's making that brain to predispose that brain to have seizures. And that structure can be anything that is in that forebrain, as could be inflammatory infectious, it could be a traumatic brain injury, it could be a congenital malformation, it could be a tumor, it could be some degenerative changes, it could be a vascular, it could be, as we said, something that the dog has been born with, so a congenital malformation, it could be a porencephaly, it could be a hydrocephalus. So you have a structure within that forebrain that is predisposing that forebrain to have seizures. And that is what is known in the group of structural epilepsy. And then how do we diagnose that? So with advanced imaging, and then we see that the structure. Sometimes it's difficult to give a final name based on the MRI findings or CT findings. So sometimes we have to combine with analysis of the CSF, or sometimes we need to get to the final diagnosis with necropsy and obviously the pathology. So when we talk about the idiopathic epilepsy, we think that in the majority there is a genetic component, although we cannot prove it. So in many of them, we end up saying that it's presumably being genetic. So how do we this epilepsy is characterized when there are not structural abnormalities in that forebrain, where we can see with the techniques that we have nowadays. So idiopathic epilepsy is probably the most chronic neurological disease that we see in general practice. More than 2/3 of these patients that come to us with idiopathic epilepsy will continue to have seizures, and some of them will have even a poor control seizure with the treatment that we can give nowadays.
Thanks, Elsa. So, well, let's move to the next question. The next question is also about, well, you have mentioned diagnose. So, which steps we can follow to diagnose these epileptic seizures? So, what are your recommendations for that?
So now we have answered the question. Obviously, is this a seizure? Yes or no? If the answer is yes, can we talk about epilepsy? Can we define the type of epilepsy? And if you suspect of idiopathic epilepsy, what is the information that you need to take into account that will make you to suspect that that dog has idiopathic epilepsy? And there are different levels of diagnosing idiopathic epilepsy. So when we talk about the level 1, where it's kind of the lowest confidence level, but again, it can be very practical, is when we have a history of unprovoked seizures. So we know that there is not any toxicity. We know that there is not any extracranial cause. The onset of the first seizure has been reported between 6 months and 6 years. And then that interictal phase, remember when we talk about the different phases of the epileptic seizures, if our physical and neurological examination during that interictal phase is normal. If we don't have any physical or neurological dysfunction that tell us there is a forebrain dysfunction during that interictal phase, that will increase our level of confidence to say this dog is very likely to have idiopathic epilepsies, and then hematology, comprehensive biochemistry is considered normal. What happens if we want to increase that level of confidence? If we want to get to the level 2, then we also consider to have the results of that liver function, so we can do pre and postprandial, but remember that that will contribute to your type of reactive seizure, so see if there is a liver dysfunction. And then image that brain with an MRI. MRI will be very good for seeing that brain parenchyma. And if the MRI of the brain is normal, if the CSF analysis is normal, that increase the level of confidence for idiopathic epilepsy. But remember that level 2 means that we have already taken into account that pull the criteria for level 1. So sometimes when we have idiopathic epilepsy and we have that dog that comes to us and he had already several tonic-clonic seizures and we perform the MRI, take into account that sometimes we can see changes in that MRI. That doesn't mean there is a pure structural lesion, but we can see some of those posictal changes because there has been that abnormal electrical activity in the brain. And those posictal changes should improve over time. So on those cases where we see some changes on MRI and we think, oh, this is probably due to the amount of seizures or due to the seizure activity, rather than being an inflammation and infectious or even a neoplasia, on those cases, we need to perform potentially a follow-up MRI to see how those episodes how those MRI changes have recovered. And the higher level of confidence is when we evaluate that electrical activity in that brain, performing that electroencephalogram. On the clinical practice is very limited on the amount of dogs that we can perform that. So usually when we get to the diagnosis of idiopathic epilepsy, we mainly are based on level 1 or level 2. So when would you consider performing advanced imaging and CSF analysis? So usually when you have those dogs that they don't really fall in the category between the first seizure between 6 months and 6 years of age, if you see clinical signs in the interictal phase that manifest a forebrain dysfunction, obviously we need to take into account that you may see dogs with some decreased withdrawal on the pelvic limbs. That will not be a manifestation of forebrain. It will be a neurological deficit, but that is not a manifestation of a forebrain dysfunction. But if you see clinical signs of forebrain dysfunction, that could fit in those cases where we will recommend to perform advanced imaging. If they present with a status epilepticus or cluster seizures, also those are the cases that ideally we should perform further imaging. Those dogs that they have been on anti-epileptic medication, even on that holistic treatment for the epilepsy, and there's still poor control of the seizures. So, as we said, what are the clinical signs that you would expect to see in a dog with forebrain dysfunction? So you can see altered mental status, you can see this walking in wide circles, sometimes we can see head pressing, we can see postural reaction deficit contralateral to the forebrain dysfunction, we can see absent menace response, we can see decreased facial sensation. So all of these are clinical signs that will represent there is a degree of forebrain dysfunction. But unfortunately, there are some areas in the brain that they still have what they are called like the silent part of the brain, which means even if we have a lesion there, they will not be manifested with a neurological deficit, and the only clinical sign that they may manifest will be seizures. So those areas are mainly the olfactory bulb and one part of the temporal lobe, which is mainly the piriform lobe. If that is a neoplastic lesion, that will continue to grow and then will affect other areas of the brain that will be manifested as altered mental status. But at the beginning, and this is a typical sign, so you have this golden retriever, he was 9 years of age, he presented because he had 3 epileptic events in the last 6 weeks. So they were at least 24 hours apart. So it falls in the category of being epilepsy. And we perform an advanced imaging because the neuro exam was normal, hematology comprehensive biochemistry was normal. So he went for advanced imaging, and we have this intraaxial lesion mainly affecting the olfactory bulb and just a little bit of the frontal lobe. So clinically, this dog did not have any neurological deficits because mainly the olfactory bulb is kind of a silent part. So it will not see any clinical manifestation, and the only thing that we will see will be seizures. But as we said, when that area continues to grow, we will see other deficits.
Okay, Elsa, then we have a global picture about what epileptic seizures are. Also, we have been analyzing the diagnostic plan. So now let's move to the treatment. And my first question related with the treatment, what would be the goal of a long-term treatment? What do you think about that?
Yeah, that's an important question that probably the owner will answer. Oh, sorry, will ask you, and we need to know how to answer. So the goal of the long-term treatment will be decrease the frequency and decrease the severity of the seizures. It's very, very unlikely that you will get a dog that is free of seizures. So the owner should keep a diary because they may remember what happened the last week, they may remember what happened the last month, but if we have to evaluate a 6-month period of the treatment, it's very unlikely that we'll remember exactly the day that it happened. So keeping a diary is extremely important. And when we talk about a successful treatment, we say when there is at least 50% decrease in frequency of what the dog had before starting the medication, and we minimize the side effects. You don't want to have a dog that doesn't have any seizures but is unable to stand up. So we have to make a balance. And a balance that we improve the quality of life of the owner and the quality of life of the patient.
Okay, so the next question is once we have talked with the owner about all the points I just mentioned, and when we have everything under control, when do we have to start the treatment, or when it's the best moment to start this treatment?
Yeah, this is not a white or black answer. When do you decide to start the treatment? Because there are some dogs that they may be a little bit borderline. So when they have more than one seizures every 6 months, then you say, oh, it's kind of the period. So to start the treatment. However, if you have one dog that has 2 seizures within 6 months and then a total of 4 seizures per year, is it still a borderline? Do we put the dog on twice a day phenobarbital, having one seizure every 3 months. So if there is a tendency on increased frequency and severity, definitely yes. If that dog has one seizure every 3 months, and then one seizure every month, and then one seizure every 2 weeks, definitely yes. As a general definition, if we have a dog that has 2 or more epileptic event within this 6-month period, then yes, we should consider starting treatment. And if we have dogs where there is a severe posictal changes, that we see there is a severe aggression on the posictal phase, we have posictal deficits that last days, so we see, as we said, a pattern of increasing frequency and severity, is also a moment where we discuss starting the treatment may be indicated. However, this is a nice study where we have seen that how is the natural course of the idiopathic epilepsy is not equal in each dog, and some dogs may be having 3 epileptic seizures in 6 months and then have nothing for a year and then continue again to have. So it's very individual, and this is why sometimes when they ask, oh, what is the protocol to treat epilepsy, there is not really a protocol, and ideally should be an individual treatment for that particular course of that particular idiopathic epilepsy in that particular dog. So before we want to start the treatment, we need to have long conversations with the owner, because this is going to be a chronic patient that we want to have and to keep very close, because we need to have the owner on board. We need to make sure that we don't run out of all the money that the owner has, because then he's going to stop giving the medication. And then we should know, depending on the medication that we are using, when do we have to do blood tests. Is a medication where serum levels are important to evaluate, and that the owner also is aware of the side effects of that medication, because if the owner knows what to expect, then it's going to accept those side effects better than if suddenly it doesn't know those side effects.
So Elsa, it seems that we have different drugs that we can choose when we are planning a long-term treatment. So if we go into more to focus on the treatment, what would be the medication that you would recommend for this disease?
So when we talk about the medication that is recommended, considering that anti-epileptics are anticonvulsants, they do not suppress the focus, they are not suppress the epileptogenesis. When the medication is recommended, if you have high frequency of those events, and also to consider that there are breeds that are predisposed to have a more severe type of idiopathic epilepsy, and we have the Australian Shepherd, the Border Collies, the Italian Spinoni, the German Shepherds, the Staffies. So those breeds, if you already have in advance, or you consider that these dogs may have a more severe form of epilepsy, those are the ones that you may want to start the medication. And as we just say on the previous slides, the protocol should be individualized for each patient, because they may have different pharmacokinetic variabilities, and you can have 2 bigger dogs, same age, same or both of them having idiopathic epilepsy, one being extremely well controlled on one anti-epileptic medication, and the other one is on 4 anti-epileptic medication and is still not well controlled. So again, we have to rely on how each particular dog responds for the medication. And when we talk about the variability, or what are the medications that are out there, you have to follow also the license in the country that you are working, but usually talking in the licensed ones, phenobarbital, imipitoine, potassium bromide are the 3 licensed ones, and then we have follow those ones other medications that we can use, and more of them again can be used in particular situations, and we talk about that. Levetiracetam, commercial name, the Keppra, is out there, and many people use it. What I would say is be very careful using levetiracetam as monotherapy, because it's a medication that is not really proven that it works as monotherapy. So if one medication might, as a general rule, what I would say, if one combination works and is not causing side effects, don't touch it. because if we start trying to touch it and then we destabilize those serum levels, we may have a go back to the frequency and severity that is bad control, and sometimes it's difficult to get back as what we have before touching those medications. So as we said, if we have a combination of medication that works, don't try to change it unless you have side effects. So we have to take into account, as we said, the medication regulations, the tolerability of that patient, the side effects, the drug interactions. They may be on some antibiotics, or they may have a liver dysfunction, where we know there are some medication, as the phenobarbital, that is metabolized by the liver in dogs and maybe less indicated than, for instance, could be the potassium bromide on these dogs. And we need to take, as we said, all these different accounts. We need to take the type of seizures that we're seeing, the frequency, the etiology, the lifestyle of the owners, the economical status. And when we talk about what is the treatment that works, what are the studies saying? So when we talk about the high good efficacy, we know the phenobarbital and imipitoine are higher, the highest level on this pyramid, and then potassium bromide, followed by levetiracetam, and then sonizumab. So phenobarbital is a very good anti-epileptic medication. It's true that we need to keep a close eye to the liver, but if it works, can be a very good as a long term. But we need to consider phenobarbital and then potassium bromide or imipitoine. But it's important that you know each medication, how much we have to wait, for instance, until we get serum levels for if we talk about phenobarbital, when we start the phenobarbital, it takes about 2 weeks to reach therapeutic levels. So during those 2 weeks, you have to consider that that dog may be not well controlled because it still hasn't reached proper levels. So we can use at that time combine phenobarbital with levetiracetam, because we know levetiracetam acts very quick. So as soon as we give the oral levetiracetam, that will reach the serum levels, therapeutic levels, pretty much within 4 hours. And this is the period where we can combine phenobarbital and levetiracetam until we reach proper therapeutic levels. And when that is reached, then we can decrease the levetiracetam. For instance, that was just an example. What I want to say with this is that because sometimes we see dogs that are with 4 anti-epileptic medication and none of them are using properly. So make sure that you know each medication and you know how to that medication works from a pharmacological point of view. So what we want to when we talk about the adverse effects, it's important, as we said, that we talk to the owners, that the owner know exactly the side effects that is expecting, because again, if they know, they will contact you and they will be less stressed about seeing them in their particular dog.
Okay, Elsa. So again, well, we are following the treatment issue. We see that sometimes even we are applying a treatment, there are no results and it does not work. So why does it usually happen? Which are the reasons for that?
Yeah, we have many times that we ask ourselves, why is not working, what happened? And sometimes when we have a patient that we think he has idiopathic epilepsy and something is not right, we have to look at different things. One will be, how much is that dog receiving the tablets? Is the owner really giving the tablet to that dog? Are we giving the correct dose? Are we underestimate the phenobarbital serum levels and we can still play within the therapeutic range? Because it may be that within the therapeutic range, even if it's in the low, we still have time or a range to increase that serum levels. Do we have a proper diagnosis? And then we have to go back to the initial question, are they really seizures? Nowadays, the owner have a video or they have a device that they can take a video. Take time and ask them to do that, because sometimes looking at the video, we can say, oh, this doesn't look like a seizure, more like a movement disorder. Potentially could that dog has a GI problem that is affecting the malabsorption of that medication? Is that reflected with the serum levels? Remember that epilepsy is just a predisposition of that brain to have seizures, or reactive seizures could be an extracranial cause. So it doesn't mean because a dog had idiopathic epilepsy all his life and now the epileptic seizures are more difficult to control, or the dog starts showing other neurological deficits. It could be that the dog now has an intracranial lesion that is also causing the seizure. So remember, the seizure is just a clinical manifestation of a forebrain dysfunction. And we have this refractory epilepsy. We have these dogs that being on 2 or more anti-epileptic medication, we still don't have a good control of the seizures. So what we want is to create or to use those medications as the maximum that we can, not maximize the use of them with the therapeutic levels that are indicated for that dog. And this is important. We don't have time to talk about each particular medication because that could be another lecture. But remember that with the phenobarbital, there are some pharmacogenetics that we should know. The same with the imipitoine and the same with the potassium bromide. And this is information that prior to saying that medication is no work, make sure that we have maximized the use of it.
So now, Elsa, the next question, I think that it's quite an important one. It's whether we have to project the treatment chronically or at some point we can consider suspending it. Which are your opinion for that?
Yeah, my opinion, as we said, if something works, don't touch it. But yes, I'm sure you will get that question from some of the owners. Can we stop the medication? And what we could say is that if definitely we haven't seen any seizure for 1 or 2 years, we could consider decreasing the medication. It's important that if the medication is decreased, that is done extremely slowly, and there are risks of relapse, and there are these risks also that that relapse will be more difficult to control. So if the owner is happy to accept the risk, then we can consider decreasing the medication. What the studies say that, for instance, those are 11 cases that anti-epileptic medication was suspended after a year being free of seizures. 4 remain free of seizures, but the majority had a recurrence. And some of them could be controlled, but some of them need a different protocol with different amount of medication to have a better control. So it's always a risk, and the owner should know that. We cannot guarantee that even if the dog has been 2 years free of seizures, if we stop the medication, the dog is going to continue like that, because that medication could be working, and that medication could be the one that is making the dog not to have seizures.
Thanks. So, well, we are almost at the end, but I have another question related with the treatment, and it's about the holistic treatment for the canine epilepsy. So, what's your definition for that, and which experience you have with this holistic treatment?
Yes, I think that will be the future, in the meaning that should be for any condition. We should just not rely on medication. We should look at the holistic part of it. And when we talk about the holistic treatment of canine epilepsy, there are different things that we should consider, and we should not rely just on the medication. So if we know that that owner takes into account that there are potential trigger factors, that every time there's X situation, the dog has a seizure, avoid that situation. And that potentially could help. The same that stressful situations, that can trigger some seizures. So if we know that every time the dog is under a particular stressful situation, try to decrease or try to avoid those situations, because that could also help to the treatment of the epilepsy. Definitely the anti-epileptic medication, there are dogs that really need those anti-epileptic medication, but take into account also the possible trigger factors, the stress factors. And then what happened with the nutrition? What do we know nowadays on the diet that potentially could help? And then what happened with the potential surgery or the vagal stimulation? There are other potential treatment for canine epilepsy, and putting all of them together, that can help us to have a better control of the epilepsy. So nowadays there are also studies coming up on the cannabidiol. What we know is that is there. We know that there is a potential benefit of it. We know that some dogs may respond better than others, but we need further studies. And what we can see is that nowadays the studies on the use of the cannabidiol are still not very conclusive, but it's an option. And I'm not saying that it doesn't work. I'm just saying that we need further studies that can help us to see in which particular dogs the cannabidiol may be useful or may help to control this idiopathic epilepsy. What happened with the diet, with the medium chain triglycerides? There's a study where it had been seen that could control the seizure frequency in dogs with idiopathic epilepsy to the point that could reduce up to 71% in the dogs the frequency. In some of them, a successful frequency reduction, which means more than 50% of what the dog had before starting the diet. Even some of them helped to achieve a complete resolution of the seizure frequency, so they were characterized as free of seizures. And what happened with that medium chain triglyceride? Why potentially could be working? Because this medium chain triglycerides, what it potentially does, it blocks the AMPA receptor. So it blocks those excitatory receptors in the neurons, and that potentially avoid the or has that anti-epileptic effect. So this is why the medium chain triglycerides could be something that could help in controlling the epilepsy in dogs presented with idiopathic epilepsy. And then the vagal nerve stimulation is something that is coming again. It was studied a few years ago, but now there are more recent studies. And what this vagal stimulation does is that we put obviously an apparatus at the level of the vagus, and that device, what we'll do is we'll send a stimulus into the forebrain, and we'll modulate that cholinergic and noradrenergic synaptic transmission that also potentially could help to control the epileptic. And there are recent studies even to make this stimulus from outside, so we don't have to make the surgical approach, but also there are recent studies where we have done this on dogs, where you just put this device in the vagus, and that send that modulation to the forebrain. And again, there are more and more dogs that are having this device placed, and this is just a recent study looking at the side effects, and one of the most common side effects for the coughing, because obviously you can see how that the stimulation can always can also affect that area. So this is something that again is a new treatment that is coming out there. Also was studied years ago, but we lack of proper studies, and now there are more and more patients that are having this. So hopefully in the near future we will have more studies that will tell us how this could work in our patients with canine epilepsy. And also with the surgery, we know that in human, if the epileptic zone is detected, potentially surgery could help on control these episodes. We're still far away from our patients on this, but it's coming out there. There are very nice studies on this, and there is just one that recently came out on the feasibility of performing the technique on these dogs, where if an epileptic epileptic zone is detected in the temporal lobe, how feasible is to perform a temporal lobectomy. And again, it's out there. There's just recent studies that potentially is telling us that is a potential treatment for particular dogs. So it's important that we don't put all the idiopathic epileptic dogs in the same box, because they can have different underlying etiology within the idiopathic cause. So as a final, what we need to take into account is definitely the owner education. So we need to have long chats with the owners, explain this about epilepsy, make sure that anything that can reduce that threshold, anything that can, as an holistic treatment, can contribute to decrease the frequency and the severity should be taken into account. And then as a conclusion, remember that epileptic events is not a specific disease, it's just the manifestation of a forebrain dysfunction. When we talk about idiopathic epilepsy, the majority will have a genetic cause, so therefore we should not really breed from these dogs. And the genetic underlying cause is quite complex. This is why it's not so easy to find the mutation in those patients. But when we talk about the treatment, there is not a magic pill that we can use. It's a combination, and when we perform more holistic treatment, the better potentially is gonna work. it's very likely the treatment will be lifelong. So it's unlikely that dog will be free of seizures if it is perfect, but the owner should not be expecting that. And what we want to combine with the treatment is that something that has the less negative impact on the quality of life of the dog, the less negative impact on the quality of life of the owner. And for that, we should not just rely on anti-epileptic medication. We should consider, as we just discussed, the holistic treatment. And with that said, I will just say thank you very much, and I will be happy to answer any questions that you have.
Thanks, Elsa. As you said, we are at the end. So many thanks for this amazing presentation. And for all our attendees, just stay connected because in a few minutes we will come back with a Q&A session. So see you now. So, okay, let's start with the first question that we have received. So the first one is about a patient with a meningoencephalitis of unknown origin. This patient has been treated and everything has been solved. So this dog has no clinical symptoms. The question is that could we withdraw the treatment, or I mean, we can stop the treatment? And if the answer is yes, how should we do it? It's your opinion, Elsa.
Okay. Well, I have a lot of questions on that, so I'm just gonna answer myself the question. So imagine you have this meningoencephalitis in that dog, and how long has been treated for? So meningoencephalitis of unknown etiology is potentially an immunomediated disease. So it's very difficult to consider when to stop the treatment, and I will not consider stopping the treatment, at least if we don't have a long-term treatment on this immunosuppressive medication. So one thing is the immunosuppressive treatment, and the other thing is the seizures. So why this dog have seizures at that time is because of that inflammation in the forebrain. Even if that inflammation is treated, even if that potential immunomediated reaction has resolved, you have to consider that they may still be a scar tissue that is causing the seizures. So even if you don't have an inflammation, even if you don't have a reactive lesion, that scar tissue could be enough to cause the seizure. So I would do the same. If the dog has been 1 or 2 years free of seizures, then you can consider potentially decreasing or stopping the medication, but always will be a risk of relapse.
Okay, thanks, Elsa. Let's move to the second question that it's also related with treatment. Well, the thing is that you have told many times that the treatment cannot work. But when do we have to consider a treatment successful or not? What's your opinion, or what the idea that we have to consider to say, okay, this treatment has been successful?
So ideally, going to the definition, successful treatment is when we have a 50% reduction of the frequency. But again, that is a little bit difficult to take in, because I totally understand. Imagine you have a dog that is having 6 seizures per week, and then you have 3 seizures per week. Oh yes, you have a successful treatment, but for me, it's not a successful treatment where we have reached down to 3 seizures per week. So ideally, it also depends on the frequency, but 1 seizure every month, every 2 months, or every 3 months will be ideal. But it also depends, because again, if we have a dog that has 10 seizures per week and we end up having 1 seizure every 2 weeks, that will be a successful treatment for that particular dog. So it's, as we said at the beginning, it's difficult to make a general statements on that, because it really relies on the frequency and severity that dog had before starting the treatment.
Perfect. I think that it's quite clear now. Let's move to the last question. So the last one is about myoclonic epileptic seizures that you have told us during the presentation. So how could we differentiate these attacks from the ones that we could observe in a dog that has suffered distemper virus?
Okay. I guess if you have a dog with suffered distemper viruses, definitely those episodes could be associated with distemper, but not the typical myoclonic seizure, because it's unlikely with the distemper that you have this head and muscle contractions like that. Usually with the myoclonic distemper is one limb on one part of the face, but it's unlikely you have these jerks movement. So that will be one of my first thing that I will look at. Obviously, these dogs will not have a history of has suffered distemper, and then it's mainly the contraction of the head and the face, and it's very abrupt contraction of all. So that will be the mainly characterized as myoclonic seizure, right? That the myoclonus for the distemper.
Thanks, Elsa, for your explanation. So thanks, Elsa. We are at the end of this webinar. We don't have more time to answer more questions, but remember that you can send us all your questions to the email direction that you can see in the description below the video. Well, and that's all for today. We will have another webinar in December talking about obesity given by Ana Vila. So we hope to see you then. And that's all. Have a nice week and see you soon. Thanks.